lectures on regional She gave some fabulous lectures on regional anesthesia. We asked her to come back. Meg Rosenblatt, who's one of her anesthesia mothers, recommended her because even though she's from South Texas, she went to New York for training at Mount Sinai. So she's bilingual or bi-regional or something like that. Moreover, she's got this rock on her finger. So we want to congratulate Dr. Hernandez and Gustavo, who's not here for their recent engagement. And, you know, it's nice. They met at the World Congress of Anesthesia. So the World Congress of Anesthesia is in Marrakesh next year, and I've made my arrangements to go. So we're going to show a 3-minute video, and then Dr. Hernandez will start her lecture. One second. Screen share.
Last winter, the polar vortex returned to wreak havoc and make life miserable for everyone. And again this past winter, we sold out our room block at the luxurious Ritz-Carlton Resort Grand Cayman. So don't delay. Register today for Anesthesia Camp Grand Cayman 2026, January 28 through 31, 2026, and make sure you request your vacation. Grand Cayman is only an hour's flight south of Miami, but almost always guaranteed to be warm at the end of January. And there are non-stop flights from many cities in the U.S. Come and enjoy the fabulous newly renovated Ritz-Carlton Resort on gorgeous 7 Mile Beach. There's great shopping, water sports, snorkeling, scuba diving, fine dining, fun for kids, golf, and whatever else you and yours seek in a winter Caribbean getaway. And remember, as a banking and financial capital, Grand Cayman has all the amenities and comforts of home. As always, we have recruited a stellar faculty. Returning to Grand Cayman by popular demand are Dr. Bobby Jean Schweitzer, Inova Fairfax, Virginia, UVA; Dr. Josh Zimmerman, University of Utah; Dr. Michael Fitzsimons, Mass General and Harvard. We are also thrilled to welcome our new faculty additions to the island, including Dr. Andrew Leibowitz, Chair, Mount Sinai Icahn School of Medicine, NYC; Dr. Anushka Afonso, Memorial Sloan Kettering; Dr. Daniel Katz, Mount Sinai Icahn School of Medicine, NYC. We will also have several individual lectures delivered via Zoom by the very best experts in their fields, giving you even more credit hours. Dr. Peter Slinger, University of Toronto; Dr. Keith Ruskin, University of Chicago; Dr. Natalie Barnett, Medical University of South Carolina; Dr. Justin Richards, University of Maryland, Shock Trauma. Your course director is once again Dr. John E. Ellis, University of Miami and University of Pennsylvania. As always, expect outstanding lectures and in-depth discussions between the faculty and attendees. You can even have small group and one-on-one conversations while engaging in case discussions on the always popular Thursday evening optional Sunset Catamaran Sail with the Professors. Our negotiated room rates at the Ritz-Carlton Resort guarantee that the room block will sell out before December. So don't be left out in the cold. Register now for Anesthesia Camp Grand Cayman 2026. See our website, destinationcme.com, for detailed information.
So, as Dr. Hernandez can attest to, it's wonderful down there. I might add that she is now, she's moved over to private practice, which I think is great because she has that background as well as having run the regional service at the University of Texas in Houston. So she's going to bring us the best of both worlds. I'm going to mute myself, and Dr. Hernandez, take it away.
Okay, I'm sharing my screen here. Hopefully It works here. But so thank you so much for having me, and thank you for having me in the Cayman Islands as well. I thought honestly that was a really well-run conference. I think I counted the other day. I've been to over 200 conferences in my career. I'm a little bit of a conference expert, I guess. So today what we're going to talk about, so I'm Nadia Hernandez. Nice to meet everybody. I did my first 10 years of practice in academics at the world's busiest trauma center. I think, working here as the director of regional anesthesia and establishing a fellowship there for regional anesthesia, I really got a lot of insight to innovation. I think in the trauma setting, you can't always do the recommended blocks, like the Plan A blocks. So I got a chance to try out blocks that weren't necessarily standard. And so I have a lot of opinions about what works, what doesn't work. Then I left last year and I joined a group that is ASC focused. And, the interesting part is they said, hey, you're regional, you can, teach everyone blocks here. And as I go to onboard new facilities, I realize that, total joints, total knees is a very popular thing, and they're all moving towards ambulatory surgery centers and same-day surgery. We did a quick review of our facilities that we have in the United States, and every total joint, every total knee that we do does get a block. And actually, when we had an ultrasound fail, our anesthesiologists and the surgeons and the surgery center administrators were all panicking at the thought of not being able to discharge these patients when they were having their total knee replacement because we weren't going to be able to do our regional anesthesia. So I'm going to try to stay on time. Disclosures is, I make some educational videos that so if you have this butterfly ultrasound, you can actually watch some videos. I'll teach you how to do some blocks on there. And that's really all the disclosures I have, other than a couple meals here and there. What we're going to talk about today is total knee arthroplasty. We're going to talk about acute pain a little bit, the importance of multimodal management, and because of the trends of regional anesthesia. And we're going to talk about the innervation of the surgical site, and then some more advanced techniques and why they may be important or maybe not. So let's start off with acute pain. I think probably this is the most misunderstood part of what we do. So of course, we're going to have two phases of acute pain. The first one is going to be during surgery, and that's phase one. And that's associated with direct damaging stimulus, right? The surgeons are cutting, sawing, and putting in, screws, plates, etc., reaming the femur. And then once they're done, then you have phase two. And so, of course, phase two is really nothing's happening to the patient. It's just a result of inflammation, and it is hypersensitivity. So when we talk about management of acute pain, oftentimes when we talked about like preemptive analgesia, people would say, oh, give local before you cut. This is preemptive analgesia. And sure, it is partial, however. When we only provide analgesia for the first 24 hours, this is kind of what we get in terms of hypersensitivity over here. Okay, this is without any analgesia. So this is what we get with single shot blocks, PCAs, PIAs. The preemptive analgesia will help you in the OR, but then still you don't block phase two. So you still get that hypersensitivity, which still puts you at risk of developing some chronic pain. Really, the best way to manage pain is to do something in the operating room, and then something that either you work with the surgeons or you put something in that can provide analgesia for the duration of the phase two. So that's kind of where analgesia for total knee arthroplasty is heading. Some friends of mine did some really, really smart things. They said, hey, why don't we take all the data from all the patients who didn't get regional anesthesia in these studies, the ones who got sham blocks, and map out their pain scores over, a few days. And what they found is that the total knee arthroplasty pain trajectory, actually these patients have, despite taking opioids at their discretion, have moderate pain for almost a week. And so it's something important to keep in mind, right? Because as we're trying to provide the best anesthesia care and the best perioperative medicine, we do want to keep that in mind. And when we talk to the patients, we want to make sure that we're working with our surgeons to make sure we do something that is effective. And so it is important that they do take opioids for almost a month, actually, after surgery. And if you look at this slide, it talks about the prevalence of chronic post-surgical pain. And of course, amputation is number one. We all know that. But a big runner-up is total knee arthroplasty. So really anything that we can do in this space is going to be really effective. It's right up there with thoracotomy. So one thing I want to talk about is, back when I was a fellow, over a decade ago, we were doing some pretty intense blocks, right? Sciatic and femoral, and we were placing catheters, and the patients didn't have any pain, and that was wonderful. However, they also couldn't walk, and they couldn't partake in physical therapy, and they had to stay overnight. So we have moved away from blocks like that cause motor dysfunction into motor sparing blocks for lower extremity. And really that's across the board. That includes for hip, that includes for everything. So it becomes very important, if you're not going to block the entire nerve, to add a multimodal pain regimen. Of course, multimodal pain regimens can be whatever is more accessible to you at your location and your practice, whether you're at a surgical center or an HOPD. Depending on what NSAIDs you carry, whether you have ketamine or not. We had to add some muscle relaxants like Robaxin to some of the formularies of ambulatory surgery centers that we took over as a group, just so that we can improve the analgesia without giving too many opioids. So this is a very important part that I try to remember not to skip when I talk about regional anesthesia, because you can do all the blocks in the world with motor sparing analgesia, but of course we're not going to block the muscles, and the muscles are getting cut. And so you have to keep in mind that there's not going to be, I'm going to give you my recipe, of course, but it's never going to be complete analgesia. So this is a very, very important part of your multimodal regimen. Let's talk about some trends and some things that you should know about that's happening in terms of pain management for total knee arthroplasty. So one of them is ultrasound guided percutaneous cryoneurolysis. Now you might come across this because when this procedure became handheld, so this is the new handheld device that came out, I want to say it was 2016, more or less, when we started using it. There was some procedures described to do cryoneurolysis, and cryoneurolysis is just really creating an ice ball inside the tissue and catching that nerve so that you can cause the nerve to undergo Wallerian degeneration. And the nerve structure remains, but it can't conduct the signal anymore until it kind of regenerates, and that takes usually 7 days to 3 months, depending on how good you got the nerve, how big the nerve was, etc. And so they came out with all these protocols to do cryoneurolysis of, first it was the cutaneous nerves. So the anterior femoral cutaneous nerves, the infrapatellar branch of the saphenous, and they called that the superficial geniculars. And they noticed that it was helpful, became popular. A lot of people were training at the sites where, these companies were having training sessions, training anybody, surgeons, PAs, anybody, chronic pain doctors, anesthesiologists. So this is going to vary depending on the site, but some places will have the PA do it, the surgeon might do it, or maybe if your anesthesiologist anesthesiology department is keen on how to do it so they can bill for it, because this gets a little tricky, you might come across this. Now, what I am going to say is that, I don't think that if they've gotten this procedure that you shouldn't do a nerve block, because what's going to happen is, and the downfall of this procedure is that if you ablate a nerve, you ablate the whole nerve. You can't selectively ablate the sensory fibers. So of course they're going to go extremely, extremely distal so that they don't cause motor weakness, or at least minimize it. And so this will have more pain, especially in that first phase 2, where the pain is very, very intense. So if somebody comes to you, they've had percutaneous cryoneurolysis, you still need to do a block. Another popular thing currently are the percutaneous neuromodulators. So the one on top is the one that's, commercially available now. It is expensive. The reason it's not used all the time is because it is several $1,000s. So what we are seeing, at least in our practice, is that chronic pain doctors are placing them for patients who have really, really bad pain preoperatively in anticipation of managing them postoperatively. So if you have a patient who comes in with a, femoral nerve PNS system, you will still, again, the analgesia is great for post-op day 2, 3, 4, 5, 6, but for post-op day 1, you still need a block. I had this discussion with the pain doctor who said, hey, my patient's coming with this device. Don't worry about regional anesthesia. And I said, okay, okay, call me if you're wrong. And of course, I work at a hybrid hospital clinically. So we have the possibility of keeping these patients overnight. And of course, this patient was in a lot of pain. We ended up having to block them. So now our new protocol is to always do a block when they come in with these procedures. The one on the bottom will be coming out soon if it's not already available. It's very, probably 10 times cheaper than the one on top, which will make it more accessible. And so what it is it looks like a catheter needle, yeah, a large gauge, and it kind of is. You put it in like you're doing a regular block, you give your local, and then instead of threading a catheter, you thread this little device that provides the same type of analgesia as a stimulator. It gets connected to the phone and you can adjust it with your phone. So you might start seeing this in the near future. Other things that are hot topics is intraoperative acupuncture. And the reason this is a hot topic is because, in this study that they did, and this is out of the primary author is out of HSS. And HSS is the Hospital for Special Surgery in New York. It's the #1 orthopedic hospital in the country. And what they've shown is that the majority of patients who had this acupuncture actually had only, 30 to 45 pills over the 30-day period, which was a lot lower than what all the other patients were having. So they found it to be very helpful. And it's such an easy thing to do. After you get trained, of course, you place the needles, and if you want to hook it to stimulate it, you can. So just another hot topic. Of course, you still need blocks, even with this. The studies included regional anesthesia. And then one newer thing, which again, this one is also a little bit pricey, but it's same principles. It's a stimulator, except they're using the sites where the acupuncture goes. And so it has been, barely coming out. This is a pilot study just to see if it's worth studying, and they deemed it worth studying. So you might see this in the future. One other thing that has changed recently is the No Pain Act that passed January of this year. And the reason I'm talking about it is because it has done one thing that is beneficial for regional anesthesia, and that is that it has given the ambulatory pain pumps are now considered durable medical equipment. So the facilities get reimbursed for these things. Our facility had a meeting with the representatives and are, happy to help us, set up a catheter program now. The benefits also is that the company will now call the patients on a daily basis to follow up, and they will actually record data to prove that it's better than whatever you were doing otherwise. And so I think it's great, because the limiting factor all the time in these ambulatory surgery centers or even in HOPDs is, okay, we can place a catheter, I guess. Of course, it's a little bit more time consuming, but who's going to follow up, and who's going to do this? And, is it worth the expense? Are we going to lose money? And so a lot of those problems have been solved. Again, whether you have the ability to place these or not, I just think it's a great thing that now they are more accessible to us. Okay, so now we're going to talk about regional anesthesia, which is, of course, probably the most important part of getting patients out of the surgery center on the same day and out of HOPDs. One important thing to consider when you look at some of these images like this is they're not always super accurate. So, I'm putting this here just so that you can kind of get an idea, but these are not always very accurate. I want you to consider the innervation of the skin because if you cut yourself, let's just say here, sure, it hurts, but then, you kind of forget about it after a little while. But if you cut yourself right here, even if it's a tiny little paper cut, every time you move this hand like this, it's going to remind you that you're having pain. And unfortunately, these incisions over the knee are just like that. So it does become very important to provide analgesia to the skin. The other thing to consider is the way bones are innervated. So bones are innervated, and again, I don't agree with this image, okay? But bones are innervated in a very special way, and I'm going to give you my opinion, having blocked bones for trauma for 10 years. Generally, the shaft is innervated by one nerve, generally, okay? And for the femur, I'm going to say that that's the femoral nerve. So you have a mid-shaft fracture, femoral nerve should cover it, unless plates go distal, and now you have, the distal femur involved or the proximal femur involved. When you start getting to the distal ends of long bones, whether it's a clavicle, whether it's the scapula, and we're talking about the glenoid process, or whether it's a tibia, or whether it's a femur, that articular part of the bone is going to have complex innervation. And that makes sense, right? Your brain wants to know what your joints are doing. So of course we're going to, whoever designed us has made it so that there is a lot of feedback from that area. So there is very complex innervation of the joints, and it's important for us to understand them. And when I saw this image for the first time, I remember being like, oh my God, I don't know what's happening here. So I just want to simplify it a little bit. And I wish the colors were different. So branches so the lower extremity is innervated by the lumbar plexus and the sciatic or the sacral plexus, right? And the lumbar plexus, the nerve that reaches the knee, is going to be the femoral. And then the femoral branches off to saphenous nerve. And it also gives off nerve to vastus medialis, intermedius, and lateralis. Then you have the sacral plexus, which gives off the sciatic nerve. The sciatic nerve then divides into the tibial nerve and the common peroneal nerve. And this nerve gives off a lot of innervation. So one is going to be these little purple sort of branches here. That's called the popliteal plexus. They are just articular branches that come off directly from the nerve. And they also come from the obturator, which comes from the femoral. And they also give off the genicular nerves. Okay, and they come from the back, and they kind of wrap themselves around and end up in the front. And there are four, of course, superior medial, superior lateral, inferior lateral. The only thing that's really not pictured here is the cutaneous nerves. So the only thing that I would add to this image is the anterior femoral cutaneous nerves, which are not pictured here. And that's it. Okay, it's not super complicated. So we're going to go now through the blocks of the lower extremity, and we're going to be targeting these nerves that we just talked about. So first we're going to do a poll, because hopefully I haven't put you to sleep yet. And we're going to do a poll to just get an idea of kind of what everyone's practice is. I'm going to wait on, oh yeah, here we go. Let's see. We're going to give it a second so that we can see the results.
Almost everyone has voted now.
All right, awesome. Okay, so I would say majority, and this reflects what I see in practice, right? We have about 60 ambulatory surgery centers that we cover. Majority of them will do either just an adductor canal block or an adductor and an IPAC. Okay, so So when I gave this talk about 4 years ago, I was looking to see what the surgeons thought about this. So these are just like, recommendations from the American Association of Hip and Knee Surgeons, from ASRA, and from the American Academy of Orthopedic Surgeons and the Hip Society, whether or not we should be doing regional anesthesia, whether or not it's effective. And the answer is that, of course, regional anesthesia is effective. They said femoral blocks cause weakness, so we should probably not do those, especially since they found that the adductor canal block and the femoral nerve block are very similar in terms of analgesia. An interesting thing is they did say continuous adductor canal block was better than single shot, which I think now that we know the trajectory of the pain makes sense. And having something for posterior pain is obviously helpful, whether that's block that we do or a block that the surgeon does. And I'm just gonna go, oh, okay, there we go. I'm gonna go over some options in a second. And so when I was a fellow and this came out, we were all excited about it. Oh, the adductor canal block. Notice here it says, so this study was comparing it to femoral and they were looking for motor weakness. And, they noted that it was only an 8% reduction in motor strength from baseline when you did an adductor canal block versus the 80% that comes from a femoral nerve block. But notice here, the description of the adductor canal block is circled in red, and they are like, okay, put it halfway between the inguinal ligament and the patella. And so, inguinal ligament is sort of at an angle. So I don't know what halfway is, but the patella is all the way down here. I mean, I'm guessing somewhere here, right? And so the question is, we all say adductor canal block. Are we doing adductor canal block? I think it's a little bit more sophisticated than that nowadays. And so here what they are showing with the yellow line is the sartorius muscle. And then what they're depicting with this teal line here is the adductor longus. So the sartorius muscle and the adductor longus, here they make up the femoral triangle. This red line shows the adductor canal. And then down here in the green, this is from the paper. This is from the paper that described the popliteal plexus block, which we'll talk about in a second. Here's where they show what a popliteal plexus block looks like. So here's a different paper, again, describing the differences in the points of injection. So if you are going in the area of a femoral triangle block, which is above the apex of where those two muscles meet, likely what's going to happen is you will block both the saphenous and the nerve vastus medialis. As you go lower, this nerve gets further and further away, and you end up having to block it separately, right? And then if you go even further down, this is now called the popliteal plexus block. What happens here is, or even if you do a distal adductor canal block in high volume, what happens here is the local spills to the back of the knee, because guess what? The femoral artery continues down the back of the leg as the popliteal artery. It's the same artery. And so that local spills to the back of the knee and covers the same nerves that would get blocked with an IPAC block, because the IPAC block does block the popliteal plexus. So very interesting, right? If you block here versus here versus here. So I love this study. I'm going to bring it up 2 times because I think it's genius, actually. I'm obsessed with the first author and the second author. Every time they talk, I listen. And so here's what they did. They said, hey, hold on. First and foremost, this orange part here on A and B is the block of the intermediate femoral cutaneous nerve or the anterior femoral cutaneous nerve. The nomenclature here is very funky. We're going to call it IFCN or AFCN. Okay. And then what they said is it better to do a proximal femoral triangle block or a distal femoral triangle block? Is there a difference? Because according to anatomy, the medial femoral cutaneous nerve, this guy here, would get blocked the higher you are. So what they noticed is if they did a proximal femoral triangle block, like they did in C and in D, plus the cuties or the anterior femoral cutaneous nerve block, they got the entire area here versus if you do a distal femoral triangle block or an adductor canal block with the QDs or the IFCN or the AFCN, whatever you want to call it, you would miss a big portion of the incision of the knee. Okay, so that's great. I do proximal femoral triangle blocks in low volume. I did get motor weakness once when I was doing 20 mLs, so I went down to 10, and I haven't had that experience since. And the original description of the adductor canal block anyway was with 8 cc's of local, so 10 mLs is plenty. So enough about the front of the knee. Let's talk about the back now. So how do we provide motor sparing analgesia to the posterior knee? So there are some options. And the question here is, how do we block the popliteal plexus? Some options here. Popliteal plexus block. In this study, they compared popliteal plexus block to a tibial nerve block. Sure, you can find the sciatic, trace it down to where the tibial nerve and the common peroneal have split, and then just block the tibial nerve. We call that a selective tibial nerve block. But do you know why that's not a great idea? It's not a great idea because if you block the entire tibial nerve, you block the sensory innervation to your foot. And I hate using this example. It's the best example that I could come up with. If you sit on the toilet for too long and you stand up and you don't know where your foot is when you're stepping on the ground, it really does impede ambulation. So even though it provides analgesia to the back of the knee, I don't think it's the best because although it's motor sparing, it does impede how you feel and interpret like where you are stepping and how you are walking. So I don't do this, and I personally don't think it's a good idea. So the other options are going to be, of course, the IPAC and the popliteal plexus block. Now I got in trouble. I give lectures all the time, and sometimes I talk about the evidence and I, try to stick to it. And then there's other times where, I read this article when it was published, which was really long time ago, actually. And the second I saw this described the anatomy of the adductor canal and how, the popliteal plexus and how it spreads if you go high volume, essentially the beginning of the popliteal plexus block. And we started doing this right away. So at the surgery center I used to work at in academics, we had ACLs, and the ACLs were having a lot of pain in the back of the knees. So they used to do IPAC blocks until, of course, somebody got the sciatic and then the patient couldn't walk home and they said, no more IPAC. So somehow I convinced the surgeons, hey, let me try this. I think it'll be similar. I don't know. He said, Nadia, I'm going to need some data. So we did a sort of an internal thing. We never published it, but we did an internal thing. And we compared the patients who didn't get the popliteal plexus block to the ones who did. Of course, they all got a femoral triangle block. And we showed that they left the PACU sooner, and that they had less opioids and less pain. So we changed our practice. I didn't have the resources at the time to publish this, but every time I talked about it, I was like, you got to do this block. It's incredible. Well, when I was on stage, so the man in this screen is Amit Pawa. When we were on stage together in Tasmania, not that long ago, maybe 4 months ago, he was demonstrating how he does the IPAC from the medial side. And I was demonstrating how I do the popliteal plexus block. And what I realized is it's the same image. Okay, so this is femur. And there is the artery. What artery it is, I guess, depends on where you are in the leg, right? But as the more distal you go, the higher you go, right, it's femoral. And then the more distal you go, it becomes a popliteal eventually. And so when he describes how to do an IPAC from the medial side, of course, he says, come in here and inject around the bone. I'm like, or you can just inject around the artery. And we both argued a little bit about it. No, it's the same thing. Okay, so maybe not. In 2025, there's actually now an RCT that compares popliteal plexus block to IPAC in the setting of total knee arthroplasty. They found that popliteal plexus block was not inferior to IPAC. It's faster to perform, and there was no patient, no single patient who had ankle weakness after a popliteal plexus block versus the IPAC. They did have some patients with ankle weakness because, you know, the nerves are close by and they're there. So I'm going to go back to my friend and be like, see, I told you it's better. I think it's easy to perform, easier than an IPAC. So I do recommend this block. Now, you know, if you're really good at doing IPACs, do you want to change? I don't think that that's a good idea. If you have a system in place and you're already doing an IPAC, I'm not going to tell you, oh, you got to do this block. But if you're not doing IPACs, this is an easy one to add to your regimen. Okay, so let's talk very quickly about the AFCN block, or the anterior femoral cutaneous nerve block. So the nomenclature here is a little sticky, right? We tried to write a paper about this when I found this nerve really high, and we started to freeze it for patients who had pain on the anterior thigh when I was in trauma. And so we used this paper to try to figure out, you know, kind of exactly where it is. But here they do show in this paper where they block the AFCN for total knees that it did decrease opioid consumption and pain. So this is my video from when I was finding this nerve back in the day. Okay, so here's the femoral nerve. There's the femoral artery. And this is very high because that's the deep circumflex iliac. Yeah. So as we come down, it comes off the center of the femoral nerve here. So you see, as you start to come down now, we are not very distal, right? Like the sartorius has not even come close to the femoral artery. So this is still really high on the thigh. This is a lot higher than I would do a proximal femoral triangle block. So just so that you can see that you do miss these nerves when you go lower on the leg. There's no way to get it. Amit's going to kill me because this is another one of his videos, but here he's showing how to scan for the cuties or for the AFC. And we call them cuties because they are, there's these little dots right here. They're so easy to see, they're easy to scan. And here's the thing, it's not an extra stick. I come in to do my femoral triangle block, I do my femoral triangle block, and then I come out and then I block these guys. So it's within the same needle stick. It's just a redirection of the needle. We were curious when we saw this. We said, hey, I wonder if these really work. And this is from my fellow from, what year was that? It's probably like 4 or 5 years ago. She found her AFCN and she put a little lidocaine there. Good news is that she didn't get the femoral, so she was able to work the rest of the day. We then went with a needle until she said ow and marked out the area of the IFCN. So I really do think this nerve is important to block. So here's that paper again. So if you just do an adductor canal block or a distal femoral triangle block, this is the only cutaneous analgesia that you're getting. You're not even getting the knee. Okay. Now, if you go higher, the cutaneous analgesia, which if you think it's important, right? That's the question. You're going to get the knee joint, but in terms of skin, if you go a little higher, you will add the medial femoral cutaneous nerve. But if you block the cuties are depicted by the orange here and here and here. So I think it's easy enough to just throw a little bit of local around the cuties so that you can get that extra analgesia for your patients. So of course, you know, backing it up with an RCT. So this is a randomized double-blind placebo-controlled trial. Here, the chief author here is Jeff Gadsden out of Duke. So, you know, high quality blocks, high quality everything. Very easy to do. So, and here he's going in plane, but actually I really like to do these out of plane. All you have to do is sort of find the curve of the femur and do the injection right on the bone. And what they showed was a pretty interesting reduction in the sham blocks took about 58 MMEs daily of opioid consumption versus the ones who got the geniculars. Geniculars, in addition to what they were already doing, had 23 MMEs. So, you know, pretty significant for something that's relatively easy. Now, I know what you're thinking. You're thinking, oh my God, Nadia, that's a lot of blocks to do. Who has time? So I'm going to show you a little way that we cheat. So I call this the Hernandez all-in-one. Some people, when they do the geniculars, sometimes, here's what I'm going to say. Okay, sometimes, chronic pain or chronic interventional pain and regional and acute pain sort of, do things or copy each other or try to apply those concepts to each other. Okay. And when you RFA a genicular nerve, sure, with an ultrasound, sure, you got to go right where that nerve is and, place your leads there. Or when you cryoablate, you have to be very specific. But we're talking about regional anesthesia, and 1 cc of local spreads the size of a quarter. So what I noticed is when we went in to do, so you add another injection at the top here of the femur. This is the top of the femur. You also get the nerve to vastus intermedius. Okay, so when we were going in to do the nerve to vastus intermedius, and we gave 5 cc's, started to spread in this direction and in this direction. And so then I was like, oh, what if I give all of my local here? Because I was going to do 3 injections of 5. What if I do 15 cc's here? And so this is before we did the injection, and this is after we did the injection. The black is the local that we injected, of course. So every time we do this block, and we come and we just go on top of the femur and inject all the local, it spreads to where we would have done the superior medial genicular, superior lateral genicular. Now, I'm writing a brief technical report, so this is not published, but I really think that it's not necessary to do all those injections separately because they are so close to each other. The only other injection that we do after that is going to be the inferior medial genicular. There's a lot of debate about whether or not to do the inferior lateral genicular because it is close to the recurrent perineal and it can cause foot drop. Some people say, yeah, if you scan and you do it on the tibia, you only do 2 or 3 cc's, it's going to help and you won't get foot drop. I don't like doing blocks that could cause foot drop. So this is the situation. Surgeon comes to me, says, Nadia, so-and-so did a block and now the patient has foot drop. Could it be your block? I didn't do it, right? Because I wasn't there. And I look at the record and I see that they did inferior lateral genicular. The answer is yes, of course. Yes, local spreads. Could it have been? Yes, I can't say no. If we did an IPAC, the same thing. Could it have been the block? Yeah, it's reported in the literature that sometimes you get foot drop. So I can't say no to that. But if you don't do it, I can say absolutely not. So with our regimen, which is what I have here, if I do a popliteal plexus block and I do the geniculars minus the inferior lateral, and somebody has foot drop and they come to me and say, Nadia, could it have been your anesthesiologist here? My answer is no. There's no way that with the blocks that we did, we could have caused foot drop, which is one of the, worst complications that a total knee can have. So of course, when they see foot drop, these surgeons are on edge until that foot drop resolves. So that's the reason why we choose these blocks. In summary, if you're going to do motor sparing blocks for knee surgery, of course, by definition, we're not blocking muscles. And the more distal you go, the more branches you will miss. It's not going to be complete analgesia. You have to set the right expectations for your patients. Hey, you can expect a pain score of about 2 or 3. Okay. In the setting of multimodal analgesia, we're going to give you, NSAIDs or COX-2 inhibitors. We're going to give you acetaminophen and muscle relaxants and a gabapentinoid and maybe a new medication that blocks sodium channels, depending on where you're at. We're going to do all of these things and we're going to do the regional anesthesia. You're still going to have pain, but we want you to have pain that you can still sleep through, that you can still be functional, you can still walk and participate in physical therapy. So remember to set the expectations. And the second thing is do not go easy on that multimodal. You need to have a good multimodal regimen for this to be successful. And then the third is really these are just my recommendations based on my practice and based on what I've seen in terms of complications, et cetera. But you can do whatever you think is appropriate for your center. a lot of the places that we take over do just an adductor canal block, whatever that block is, femoral triangle, whatever, and the patients get discharged. So it's not to say that if you don't do this, your patients won't go home. I just like it when I see the patient the next day, or I call them and they say, "Oh, my thigh hurts," and I'm like, "Oh yeah, that's the tourniquet," but definitely not from our blocks. Okay, I'm going to leave 10 minutes for questions. But my name is Nadia Hernandez, and thank you so much for listening to Regional Anesthesia for Total Knee Arthroplasty, What's New in 2025. I will stop sharing my screen.
Nadia, thank you so very much. That was fantastic. I put two questions in the chat just to get things started, but if anybody wants to come on and ask questions or make comments, please go ahead. I see people clapping here, so that's always nice to see. Anybody with a question here?
Okay, I see a good question. It says gabapentinoids still. Okay, let's talk about that. That was a big meta-analysis in anesthesiology. I think it was in anesthesiology, where they talked about gabapentinoids and their role in postoperative pain. Now, I'm very opinionated on this topic because they included all types of surgeries that may or may not have neuropathic pain involved in the postoperative period. And I don't think it's a good study, in my opinion, because I don't give gabapentinoids to every patient that has surgery. I give gabapentinoids to patients who have surgery where nerves are cut, where you can anticipate neuropathic pain in the postoperative setting. And total knee arthroplasty is one of those surgeries. So it is my opinion that gabapentinoids are very helpful in this setting. Now, of course, within reason, right? Like if you have a 80-year-old coming in, you do have to be a little bit careful because sometimes the sedating side effects can contribute to, not necessarily getting out of the PACU in 2 hours. So you do have to be careful, but I think they're important. Okay. Who's using the sodium channel blockers? Okay. So, okay. When I looked at suzetrigine, which is the new sodium channel blocker for pain, the FDA always requires two studies, right? They want a study in soft tissue and a study in bone. And if you remember the studies for liposomal bupivacaine, I think they did bunionectomy and hemorrhoids, right? And so the studies for suzetrigine were podiatry cases and plastic surgery. Um, I there's a few things that I didn't like about the studies, and one was that they compared it to scheduled combination opioid drug that, was scheduled every 6 hours. My critique there is like, that's not how we treat pain. I needed a more realistic comparison. Just because your drug is scheduled doesn't mean that, this drug should have been scheduled in the study. And so I didn't like that. Other things too is that there wasn't a lot of data in the older population, which that's where I really struggle to find medications for multimodal analgesia, right? Because that Beers criteria, that includes NSAIDs, it includes a lot of things. And I'm like, well, if my patients are having the surgery and I can't give them NSAIDs and I can't give them this might be a really good drug. It's just not that they just didn't include those patients. Do I think it might have a role? I have heard of some people. So generally the surgeon writes a prescription and then the patients can start taking it pre-op. They can take their loading dose pre-op the day of and then continue it post-op. I have heard that in this setting of, of course, it's not going to take over opioids, but in the setting of multimodal, it can be very opioid sparing. So no personal use though. We are still working on that. Let's see.
So someone said, this is Elise, I think, in here, mentioned,
Yeah.
Elise Lofton, you see here, says we've started using select patients, especially in the elderly.
Amazing. Yeah, I think again, I think it's great. I don't think that we should exclude it. My questions at the beginning were like, hold on, it's blocking sodium channels. What's going to happen to my blocks? Are they still going to work? Because if they're blocked already, and this is more powerful than what I'm doing. But yeah, it hasn't, from what I understand, it hasn't interfered. Let's see. Additives to your local. So we are really big believers in perineural dexamethasone. I always tell this story when I was a fellow, we were very, clean in our blocks. We didn't have any additives. It's off-label use, da 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 da. And then I talked to someone who I respected really well. They came in, they gave us grand rounds, and they were really surprised by all the catheters that we were doing at the time at our trauma center. And I remember them saying like, man, why do you guys do so many catheters? And I was like, well, I mean, don't you guys do catheters? Because you guys do these big surgeries over there and it's ortho. And they're like, no, we use dexamethasone. And then I was like, well, the studies show that if you give it IV versus if you give it, perineural, and he was like, no, I don't know who did those studies. I don't know where they're injecting. It works, just try it. And so what we did is from one day to the next, we started adding it to our blocks. We were already giving it an IV because everybody gets it for post-op nausea vomiting, right? So we were already giving it IV, but this time we started adding it to our blocks. And it was such a huge difference for us. Instead of the blocks wearing off at night, rounding on the pain service in the morning, we were rounding at 1, at 2, and people were still having motor blocks. So it added a good 12 hours to the lower extremity. So after that one, I became very suspicious of all clinical research that I read. But now I think the literature is again leaning towards perineural. So I'm a big fan of dexamethasone, and that's all we add to our bupivacaine, 0.25%. And then somebody says liposomal bupivacaine question mark. Okay, here's another hot topic. And I should have probably put a slide in here about Exparel. And so here's what I'm going to tell you. Okay, so again, the study in anesthesiology was a meta-analysis on the duration of action of this medication. And I think it's a controversial medication because it is so expensive, right? I didn't like that meta-analysis for the same reasons, the heterogeneity. So I think they had dorsal penile block, they had tap blocks on there, interscaling. And I have to tell you something. The duration of bupivacaine depends on where you put it. It depends on the vascularity of the region where you're injecting, right? So interscaling versus popliteal block versus serratus plane block versus epidural. Epidural bupivacaine is 2 hours. So the duration of a bupivacaine in a liposome is going to depend on the vascularity of where you are injecting it. It's very similar. I think adding this medication increases the duration of the block by 2 or 3 times. So if you put it in the epidural space, for instance, I don't think that's a good idea, because if bupivacaine lasts 2 hours, this medication will probably only give you like 6, 8. Surgeons do it sub-Q. I had Exparel myself, actually, in the sub-Q region injected by the surgeon. I will tell you, 24 hours afterwards, I felt a big difference when it wore off. And it's because if you do it sub-Q, it does last 6 to 9 hours. So again, to my theory, if you inject it in the liposomal form, it is going to give you a few more days. So I do think it is a good medication. It's just that it doesn't spread. So 1 cc of local spreads about the size of a quarter, and 1 cc of liposomal bupivacaine spreads about the size of a dime. So if you don't put this medication exactly where it needs to go, and all of the medication exactly where it needs to go, I've watched a lot of people do blocks in my career because I trained residents. Sometimes they're doing a popliteal block, the needle goes in, they start injecting, the needle comes out, half the local's outside, half the local's in here. You really have to be meticulous and watch the whole time. If you put all of that local where it needs to be, exactly where it needs to be, it will extend the duration. So if I was going to have it, I would want at least the main blocks to have a little bit of liposomal. That's just my personal opinion.
Lots of questions.
How do you determine if you are too proximal or too distal? Do you look for the, so I don't look when you're in the femoral triangle. Um, you can try to trace it, but it's not necessary because I just go, I go high. That's a really good question. I don't have an answer for that because there's not like a delineation. So if you put your probe on and you see, let's just say mid thigh, you are 100% going to see the adductor longus, right? And so if you start to trace it down, the adductor longus gets smaller, eventually it disappears. So now you know you're at the apex or the distal part of the femoral triangle. So then I trace it, I try to see, because everybody's anatomy is a little bit different. I try to see how far that is from the inguinal ligament. And then I just kind of go somewhere in the middle. So not a scientific answer, but that's just kind of how we do it. And just to clarify,
Devin is our annual HHS visitor. HSS, forgive me. Thank you,
just
Devin, for that question.
just to clarify, how many needle punctures do you make for the blocks? One for, yeah, so one for the femoral triangle, and I block the cuties in the same needle puncture. So that's one. One for the popliteal plexus, that's two. One for the Hernandez special, that's three. And then one more for the inferior medial genicular. So it's really just four. And my record for this is 5 minutes. If no one is talking to me or I'm not telling jokes, generally I'm asking the patient, is this the right side? Or, oh, this is my first time. I just try to make it light. So if I'm not being a clown, we can do this in 5 minutes or under. How much local do you use for each of these blocks? Okay, that's a very good question. So we always drop 50 to 60 mLs of local. We always use 1/4% bupivacaine and never 1/2%, because of course, if you double the concentration, you're gonna only be able to inject half of the volume. A good rule of thumb that we use when we're calculating max doses is if you look at the max dose of bupivacaine, it's a range, right, from 2 to 3 mLs or milligrams per kilo. And luckily, 1/4% is 2.5 milligrams per ml. So if you just go right in the middle of that range and you say, hey, the max dose is 2.5 milligrams per kilo, and you use 1/4%, then that means you can use 1 cc per kilo. So 50 to 60 cc's on an average adult still gives us plenty of room because this is using a conservative max dose of 2.5. So let's just say me, I'm 70 kilos, for example. I'm really not actually. If I'm 70 kilos, you give me 50, we could still do another 20. And if we wanted to be fancy, go back and calculate the max dose based on 3 milligrams per kilo. You still have a lot of room. So it sounds like a lot, but because we use 1/4%, we still have room. We allow our surgeons to do the peri, they do some peri PAI with what they refer to as rec solution, which has ropivacaine, epinephrine, clonidine, and ketorolac, hence rec. So we still allow them to do that because we made sure that our blocks plus their PAI isn't going to, you know, cause the patient any harm. Um, do I not? I still block the posterior knee because I don't trust them. And I'll tell you why. I have never seen an orthopedic surgeon do their own PAI. It's always done by whoever's closing, okay? And I do not trust them. So I always do my own block, and I'm a very friendly person, and I say, sure, do your PAI, no problem, but I'm still gonna do my block. So that's a good question. And then, do you use magnesium sulfate and ketamine? And yes, we try to use both. You know, depending on the patient, right? But if as much as we can, we do try to use both of those in our multimodal. How much local do you add? So I do 10 in the proximal femoral, you know, a few 5-ish in the cuties. That's the 1 stick. So that's 15. And then I do 20 in the popliteal plexus. That's 35. And then the rest of the local, it depends on how you know, the patient looks, how the block looks. Usually 10 to 15 for the 3-in-1 thing, or, you know, 5 per if you want to be more meticulous. And then 2 or 3 for the inferior medial. So it's not always the exact same. It's usually approximately, depending on how the local looks and, you know, whether it spread well or whether it didn't. Sometimes I'll reposition and inject a little more. Do you feel you have trade-off by doing femoral triangle block and having to use less volume, better block, but less duration due to having to? So interestingly, the duration is the same. I know 20 makes people feel good, but the duration of this block is the same all the way down to 10 mLs. I think 8 mLs was the original description. And we are, if you think about it, we are blocking those same nerves a little bit lower with the popliteal plexus block. We're just adding, because you still block the popliteal plexus, you're still blocking the saphenous. You're still blocking. So you're kind of getting them twice, even though the whole goal of popliteal plexus is for it to spread. You still kind of block those nerves twice. So with a lot of local. Any experience in any of your centers with Zenrelef? So luckily, no experience with that medication. How much dexamethasone do you add to blocks? So we add 2 to 4 milligrams per syringe of 20. And we, draw up about 50 to 60 mLs depending on the patient, the day. So it's usually a total of 5 milligrams. And is that 10 milligrams concentrated? Yeah, so yes, it comes in a 1 ml vial that's 10 milligrams and it's preservative free. It is off-label use, yeah. So we still try to use preservative free, just to be careful. And then we just draw it up with like a TB syringe and divide it. Or, I think when I did my pediatric rotation, I was really bothered by having to look to see how much I was injecting everywhere. And when I do adults, it's like a little bit of this, a little bit here, a little bit there. So sometimes we're not so exact when we put the dexamethasone into the blocks. I just do a little, almost like an epi wash. We cut a little dex wash in each of the blocks. And I don't trust them. I think that's it. I think we answered all the questions. Thank you again so much for having me. I hope this was helpful, and you can always send me an email or a text message or DM me on the socials if you have any more questions.
Yeah, we'll send out an email with a link to the recording of this. Dr. Hernandez has been gracious enough to allow us to do that. I think you get an example of the kind of faculty we have down in Grand Cayman. We'll be back there at the end of January of 2026. And, our room block's filling up fast. So if you want to come in, escape the cold, join us. So Dr. Hernandez, once again, I want to thank you and go on and everyone enjoy. And hopefully some of you will come back on this and watch this video or share with your colleagues so you can tell people how to do things right. All righty, everybody. Thanks so much for joining. Thank you so much, Nadia. Take care, everybody.